Hello, everyone, and welcome. I am Dr. Mohammed Ranavaya, the Senior Associate Dean of Marshall University School of Medicine CME Division. And today we have a CME On-Demand Activity presented by our Dean of Jones C. Edwards School of Medicine on the topic of Snoring Child. This is going to be a two-part series. Dr. Gozal would be presenting the first part today. This activity is accredited by Marshall University School of Medicine for 1 hour of AMA Category 1. Marshall University School of Medicine is an accredited entity by the ACCME, the Accreditation Council on Continuous Medical Education, to provide Category 1 CME credit to physicians, licensed practitioners. And this activity at the end will have some questionnaire evaluation. If you fill that out, you would be receiving your credit. Before I invite Dr. Gozal, let me briefly introduce his illustrious career as an educator, as a doctor, as a physician, as a consultant. And he began his career and did his MD, Doctor of Medicine, from Hebrew University of Jerusalem and MBA degrees from Georgetown University. He completed his pediatric residency at Haifa Medical Center in Israel, and then spent 2 years in Cameroon, West Africa, developing rural healthcare network, for which he received the title of the Knight of the Order of Merit. He then completed his pediatric pulmonology and sleep medicine training at Children's Hospital, Los Angeles, and joined the faculty at the University of Southern California and UCLA. From there, he served in leadership roles at various leading universities, including University of Chicago, Tulane University, University of Louisville, and University of Missouri. And currently, he is the Dean of Jones C. Edwards School of Medicine and Vice President for Health Affairs at Marshall University in West Virginia, a position that he has assumed in July 2023. Dr. Gozal is past president of American Thoracic Society and was a member of the board of directors of the Sleep Research Society from 2014 to 2016. He is a leading authority on sleep research and has published numerous papers and was the senior deputy editor-in-chief for journal Sleep and associate editor for European Respiratory Journal, Pediatric Pulmonology, and several other journals, including AJR-CCM. Among his many awards and accolades, he was the recipient of ATS, American Thoracic Society Emberson Lecture in 2002, the William C. Dement Academic Achievement Award by American Academy of Sleep Medicine in 2013, and the 2016 Lifetime Achievement Award of National Sleep Foundation. He has been also bestowed 2 honorary doctorates from University of Barcelona and University of Lleida in Spain. He has published more than 950 peer-reviewed original articles carrying a H index of 149 and more than 100,000 citation, along with more than 200 book chapters and reviews, edited 7 books, including the reference textbook in pediatric sleep medicine, presented more than 1,500 scientific abstracts, and has extensively lectured all over the world. I can continue on the great accomplishment, academic accomplishment of Dr. Gozal, but then it will leave him 5 minutes for his presentation. So without further ado, I will invite our Dean, Dr. David Gozal, to give us a presentation on the snoring child with a subtopic: snoring is more than just a loud nuance, or nuisance rather. Thank you, David. Please.
Thank you, Mohammed. Thank you, Dr. Ranavaya, for a kind introduction. Hello, everybody. I hope that you will enjoy this part 1 and that it will trigger enough curiosity so that you will also come back and listen to part 2. And through that, you will get a perspective over what sleep apnea in general is, but more importantly, as it relates to children. I'm a pediatrician by training, and so obviously my job as a pediatrician is to make sure not only that we take care of children and make them healthy, but may also sure that they become healthy adults, and that's an important mission that transcends just the age of childhood. My objectives today are one, and a little bit of an overview of sleep apnea as really a growing problem in our society and elsewhere around the world. I will tackle a little bit about diagnostic challenges of sleep apnea, but that will be part 2, and then a test as well as phenotypic variants and treatment. And all these 3 areas, because of the complexity of understanding what sleep apnea is, why it's growing, and the pathophysiology of it, will be dedicated today mostly, with the other 3 then serving as the part 2. And if you all want, I'll be happy to expand then into cases and do a 3rd part if that would trigger your interest, and by doing so, expand a little bit the application to your practices wherever you may be. I have no conflicts of interest to declare. The only funding that I receive is currently from the National Institutes of Health, and so otherwise nothing else. Let's first some concepts that are important. First, what is obstructive sleep apnea? It consists of the intermittent, partial, or complete occlusion of the upper airway during sleep. That's pretty much what sleep apnea is. Now, there's a difference between obstructive sleep apnea and obstructive sleep apnea syndrome, or OSAS. One is an event, the obstructive sleep apnea. See, the syndrome indicates a constellation of both symptoms, consequences, and of course, the events that of obstructive events that I just reported. These can, of course, translate into, if those events take place, they can take consequences, physiological consequences, disturbances in homeostatic gas exchange, such as elevated carbon dioxide, you have an obstruction of the airway, or an increased resistance of the airway. CO2 will go up. At the same time, the alveolar ventilation will decline, and that can lead to reductions in saturation, oxyhemoglobin saturation. And due to the ongoing respiratory effort, these can trigger arousals, which will then lead to discontinuity of sleep, which then translates into a perturbed sleep architecture. Interestingly enough, Mackenzie, who was an ENT surgeon and was doing actually tonsillectomies at the time for recurrent tonsillitis, was the first that observed the phenomenon of sleep apnea in a child. And so this goes back to 1880. But they didn't know what it meant. They didn't have the tools. They didn't even know how to measure oxygenation or any other physiological measure that we do today. So the reality, if you want to think, is that we are celebrating this year the 50th anniversary of the true discovery of obstructive sleep apnea syndrome in modern age. And this was done by Christian Guilleminault at Stanford and his colleagues. Unfortunately, Dr. Guilleminault, a very dear friend of mine, passed away a few years back. But he really, in a paper in Pediatrics, he described 6 children at the time that fulfilled the criteria of severe obstructive sleep apnea syndrome. And since then, we have made quite an inroads into an understanding of this disease. And today, I'll present some of these insights as we have developed them over the last half a century. So the first thing that you want to, and I stopped here at 2005, but I want to illustrate is that from 6 kids back in the 1970s, I started my own practice in pediatric sleep medicine in 1981. That dates me a little bit, when I completed my training in pediatric sleep and established the first sleep laboratory. But just to show you that the number of patients per year, as shown here on the right upper quadrant, has increasingly includes and expands in any given setting. And today we see quite a few thousand of children that come to the laboratory and to the sleep clinics in order to receive care for suspected sleep apnea or symptoms compatible with sleep disorder breathing, which are, of course, needs to be evaluated. And you will also notice, and one thing that I will talk more during my talk, is the fact that there are some elements that are also quite important. One, we see that obesity is taking a preponderant role in the overall percentage or proportion of children that come to our clinics. Two, that there is an elevated presence of asthma. About 10% of all children that come have either asthma, or about 20% will report allergic rhinitis. That it's an interesting phenomenon that links very much to the phenomenon of sleep apnea, and that only a portion of about 20% or 25% will actually present with excessive daytime sleepiness, which is an important feature that we all know in both the adult world, but also from the pediatrics, and we'll talk a little bit about these things and the differences between children and adults. So what is the prevalence of sleep apnea in children? Interestingly, it is a very difficult question to answer. So the first thing that I want is to illustrate that the syndrome goes all the way, as shown here in the bottom scale or graphic, is that, first of all, we need to say that snoring is not normal. None of us should snore. Presence of snoring attests to the presence of upper airway resistance, or increased resistance of the upper airway. That leads to vibrations that through the vocal cords will translate into the noise that some of us may be endearing in certain cases, in others quite disturbing. And you can think of, in a marital bedroom, one of the spouses being unable to sleep properly because the other spouse has very loud snoring and disturbs the sleep of the partner, the bed partner. But in children, it is quite frequent, and depending on the surveys, about 27% of children have been described as having some degree of snoring. Now, we coined about 25 years or so ago the term of habitual snoring in order to unify the definitions, and also because there is a substantial significance to as far as disease prevalence and so on. And so what we describe as habitual snoring is the presence of 3 times, so 3 nights or more per week, as identified by a caretaker. You don't know that you snore. Somebody needs to tell you that you snore, and because you are asleep. And so parents or caretakers that notice and document that their children snore 3 or more times nights per week, that's considered habitual snoring. And when we do surveys of population, as they have done in the United States and around the world, we find that between 7 to 12% of all children, otherwise healthy children, will have habitual snoring. So you can see it's a very frequent disease, or a very frequent condition. Now, not disease, because now when we apply very stringent criteria, and we'll talk a little bit about how to transform the criterion of snoring or habitual snoring into disease phenomena, there's a very simple principle. If any phenomenon, any symptom translates into consequences, adverse consequences, morbidity, then it becomes a disease. So snoring alone, if you cannot show that it associates with any adverse consequences, you cannot call this a disease. You can call it as a phenomenon, a symptom, but that doesn't mean that it has any evidence. And primary snoring is what we term as snoring that, at least in our current tools, we cannot see that it's associated with evident morbidity. So primary snoring affects about 9% or so of all children, with the rest, the other 3%, affecting and creating evident morbidity. And in this case, we have 2 conditions. One, upper airway resistance syndrome. So in other words, there is increased resistance of the airway, enough to cause symptoms, may have more arousals, more fragmentation of the sleep, maybe a little bit of increased carbon dioxide, but no significant desaturations. And that is a condition that is rather frequent. And we will talk a little bit about how to address this, because it's obviously there's a risk-benefit ratio and to potential interventions when we tackle the issue of treatment. And then obstructive sleep apnea with degrees of severity, where you have intermittent upper airway obstruction associated with morbidity. So you can see this is a complex spectrum of disease that then leads to a variety of considerations of trying to understand why it happens, and that's what we're going to focus today. So the first element that I want to emphasize is you will not be able to diagnose sleep apnea only on the basis of a history and a physical exam. That has been repeatedly shown over multiple papers that there's an inability to, just by virtue of taking a history and performing a physical exam, that's not sufficient. And so our guess rate is exactly the same as that of the receptionist. When we try to guess, just as we see those patients in the clinic, do they have sleep apnea or not? Our guess is probably as good as that of the receptionist. In other words, parents, anybody else can make a guess, and we will make a very similar guess and a very similar accuracy. And therefore, a recording, an objective recording, such as overnight polysomnography or sleep studies, need to be done. Obviously, they need to be done in conditions that are appropriate for children. It is better to lead them to some degree of habituation. It's absolutely painless, but nonetheless disruptive to families. And so when we talk about diagnosis in part 2, we will talk about alternatives to polysomnography. But the gold standard is the sleep study. And in the sleep study, we put in a very large array of multiple measures, such as electroencephalography, shown here, electrooculograms. We put measures of myography, both on the chin in order to see muscle tone, but also in the legs and in other sites, such as the diaphragm, and superficial on top of the diaphragm in order to recruit the respiratory activity. We measured electrocardiography and, of course, pulse oximetry, end-tidal carbon dioxide, and et cetera, et cetera. So you can see that this is a complex array of many measures in order to derive both the sleep state, the sleep stages, and respiration, hypoxia, EKG for cardiac monitoring, and sometimes we do even more sophisticated components in case there is a reason for those. For example, we can do a pH probe at the same time in order to track whether this child has gastroesophageal reflux that is causing specific phenotypes during sleep. This is I'm going to play a video just to give you a permission from the parent to show this. You can see how this child who came to my clinic some time ago illustrates, and I'll play it again, illustrates this paradoxical breathing with use of accessory muscles at the same time that you can hear it clearly. There's some features that I would like to point out in this particular child. First, you can see that the chin is relatively inwards. There's a certain degree of retrognathia. He is breathing with his mouth open. Oral breathing is very frequent in children with habitual snoring. And that probably is a perpetuating effect on the growth of the mandible and of the upper airway cavity, because if you do not breathe through your nose, the stimuli that leads to some degree of bone morphogenic proteins and leads to an enhancement of bone growth, particularly of the maxilla and the mandible in particular, may not take place. And so a chronic mouth breather will have more likely to have what we call a relatively hypoplastic mandible, manifesting as retrognathia, with a high arch palate and a narrow palate, all of which favor a relatively smaller airway. But the important part that you see here is what we call an hypnogram on the right side, and I'll focus just on a few points. First, deep sleep is shown here in blue or teal, and you can see that our first stage in the top is we go through deep sleep. Then the black and pink bars show rapid eye movement sleep or dream sleep. This is a very vulnerable period for breathing since we're paralyzed except for the diaphragm. So there is a very significant decrease of the upper airway tone during sleep. And so if you will notice in red and in blue, these are both the events of both apneas or hypopneas, which means increased upper resistance with gas exchange abnormalities or arousals. You can see that they seem to coincide in this particular child during REM sleep. And so if you were to ask, when do most of the events take place in otherwise a non-obese child, your guess will be very good if you say rapid eye movement sleep or REM sleep. And you can see that there's clustering of both the saturation dropping during these periods, et cetera, et cetera. So this is what we would see with a child with relatively severe sleep apnea, and I just wanted to illustrate one of the many that we see during these events. Trying to move the cursor. Now, this is a recording, just to get you a little feel for why we do certain things. This is a recording, a very 30-second recording, and another child. These currently rapid eye movement. You can see the paradoxical movements of the eyes. You can see that there is snoring, as shown here. The noise is evident, but the saturations are normal. And for the most astute of you, and I'm sure that all of you, there's normal airflow, what appears to be normal airflow, and yet you will see that there's paradoxical breathing of the chest and abdomen. Then looking at each other as opposed to moving together. What that tells you is that you have snoring, you have increased upper airway resistance, but yet everything's to be normal unless you measure end-tidal CO2. And so when you measure end-tidal CO2, you can see that it's 61. That indicates that this child is obviously has significant obstructive hypoventilation, and this is a very typical feature of children with sleep apnea or with snoring. They may develop what we call an obstructive alveolar hypoventilation, and it is one of the clinical features that you can only diagnose in the laboratory if you're properly equipped, and that's why pediatric sleep laboratories are a little different from those of adults, and you will see also the criteria in which we base our diagnosis are different from those of adults. Children are not small adults. This is just to illustrate what an event looks like. You can see here desaturation shown in red, and you can see that there's cessation of airflow with ongoing respiratory efforts, and then terminated here by anaerobic. Okay, and these events occur one after the other in clusters or occur isolated. And this is just another example of a very disrupted night where dream sleep or REM has gone much lower. And this is an obese child with severe sleep apnea, happening both in non-REM and both the stages 2 and 3, which are increasing depth from stage 1, which is only the beginning of sleep, as well as during REM. This child is having significant events throughout the night. Let me put it in other terms. If you calculate the number of events per hour that this child during sleep, that what this child had was about 40 events an hour. That means that 40 times you have either desaturated or you have had to wake up in order to recover your breath and breathe and not die or completely asphyxiate in the process. So how do we define severity? This is just to introduce the concept of severity of disease. In children, less than 1 is normal. So that would be considered as primary snoring, but any event between 1 and more than 1, certainly more than 2, and less than 5 would be considered mild sleep apnea in children. You can see that for adults, 5 is the lowest number of normal. In other words, if you have less than 5, you're absolutely normal. So the collapsibility of the airway increases as you become older, and once you become beyond the age of 18, the norms that need to be applied are between 5 and 5. But before that, we recommend, and based on the normative data that we have established, we recommend the use of 2 to define mild sleep apnea. And between 2 and 5 is mild, 5 to 10 is moderate, and then more than 10 is 10, wherein in an adult, more than 30 would constitute severe sleep apnea. AHI stands for apnea hypopnea index. In other words, the number of apneas and hypopneas has increased upper air resistance with disturbances in gas exchange or arousal. The total of events divided by the total amount of sleep gives us the kind of metric that we use in the process of making the diagnosis. Now, what is the magnitude of the problem? Well, we talked about the about 75 or so million, maybe 80 million now in the US. So half of them are between the ages of 1 to 9, which is when the mass majority of sleep apnea occurs, at least due to the usual features that I will talk about. It can happen at any age, but this is the peak age is between 1 and 9. And about 11 to 12% of these children would have habitual snoring, which put them at 4.5 million. And if 2 to 3% of these have, in other words, of the total, have sleep apnea, then we would talk about 2.5 million of children would have sleep apnea, which is a huge amount. And that means that many of the kids with sleep apnea are not being diagnosed because of unawareness of either the parents, primary care caretakers, etc. Now, what are the conditions that are associated with sleep apnea? It is not a single disease, not a single process. And I'll try to make some sense into all these, but I wanted to alert to you that you need to start thinking of all of these conditions, because if you have a patient with any of these, your alertness towards the possibility that they may have obstructive sleep apnea needs to be increased. So the more frequent two conditions are, of course, adenotonsillar hypertrophy and obesity. But if you are from Asian extraction or you're African American, you have an increased risk. If you have allergic rhinitis, you have an increased risk, about 12, as opposed to 2 to 3%. Kids with allergic rhinitis, between 20 to 30% will have sleep apnea. Kids with asthma, there's an overlap between asthma. It's all, after all, we're talking about the same airway. So allergic rhinitis and asthma seem to overlap with sleep apnea. And again, about 20% of kids with asthma may have sleep apnea. And if there is sleep apnea, it will also make the asthma worse. And we've shown that as well. Kids with obviously congenital micrognathia, kids with Down syndrome, 60 to 80% of all kids with Down syndrome may develop sleep apnea during their lifetime. It goes without saying that all the craniofacial syndromes are at very high risk of sleep apnea, such as Treacher-Collins, Pierre-Robin sequence, Apert syndrome, Crozon syndrome, achondroplasia. Kids with mucopolysaccharidosis, kids with microglossia, sickle cell disease. 40% of all children with sickle cell disease may have developed sleep apnea due to the inflammatory process that is present in this disease that leads to exaggerated growth of the adenotonsillar tissues. Myelomeningocele and other conditions such as neuromuscular disorders and cerebral palsy are again very high frequency of sleep apnea in these children. And of course, kids with cleft palate, particularly if it's the hard palate that is affected, need to be at very significant risk of having sleep apnea. In fact, despite all of these diseases, when we start asking at clinical findings, you will see that it's quite limited. Habitual snoring, we talked about it. Difficulty breathing during sleep with snorting episodes. That's one thing that some parents may be able to notice, not necessarily. The parents will usually tell us that the children have either excessive sweating, or that they are restless and they have frequent awakening, that they have more nightmares and night terrors, that they may have bedtime wetting, or that they see breathing pauses. That's about it. That's all you're going to have. During the daytime, they may tell you that they notice that these kids are mouth breathing, or they are congested with chronic rhinorrhea. They may have adenoid facies. They may report a history of recurrent ear infections and otitis media. Because of large tonsils, they may have difficulty swallowing, or there's a high proportion of children that may present with pectus excavatum. Retrognathia is one of the things that we may notice, but it's for obese, enlarged neck circumference, and truncal obesity may be features that you may notice. And then a very frequent visits to the primary care physician for respiratory-related symptoms should alert you to the possibility that under these visits, there might be a condition such as sleep apnea that is contributing to these visits. Now, the major consequences, and we'll talk much more in the part 2 about what the mechanisms of this may be, are a long list of morbidities that are very important. The most important of which, of course, is neurobehavioral and cognitive deficits that may manifest as poor school performance, learning deficits, aggressive behavior, moodiness, shyness, and social withdrawal. Very difficult to pick up. Attention deficit hyperactivity behavior. In fact, we estimate that of all the ADHD conditions that we see today that account for about 10% of all children, there's at least 30% of these that may have an underlying sleep disorder breathing that may be contributing to the severity of their symptoms. We know that there's association with depression and low self-esteem. Excessive daytime sleepiness may be a manifestation. And then cardiovascular components, such as systemic hypertension, changes in left ventricular hypertrophy and geometry, pulmonary hypertension for the more severe cases, And in some, rather than the obesity, you may see actually failure to thrive, all of which may then lead to very significant reductions in quality of life, and quality of life can really be affected in a very serious fashion. Now, for many years, we heard from our radiologists at the time that they did lateral films of the neck that the tonsils and adenoids grow disproportionately to the rest of the other structures of the airway, grow disproportionately during the period of age between 1 and 8. And so it was not surprising that because of that, that the frequency of sleep apnea would be highest during that period of time. Now that's one aspect that evolutionarily does not really make sense. Why would something grow more just because during that period of time? Well, one of the explanations that was given is, well, you're exposed during that period of time to a lot of infections of the airway. You're going to daycare, you're going to school, you're having other kids, the snotty kids, one will communicate to the other. And so that may be the reason. But that's pathology. That is not the normal growth. So we asked a very simple question, and Dr. Ahrens, Ronnie Ahrens at Montefiore, who was one of my fellows many years ago, did a beautiful study, which I will present to you, that shows he used MRI in order to avoid radiation, and that today is probably the more appropriate study to be done if you really want to have an assessment of the airway and all the structures, and then segmented the airways and each one of the structures in order to measure what happened in otherwise completely healthy kids that are non-snoring, to see what happens to the lymphoid tissues of the upper airway through age. In contrast, he also took kids with sleep apnea that were defined by an overnight sleep study, and also measured these same structures, and then took some comparisons to look at both. And so the first thing that I want to show here is that in otherwise healthy children that do not snore, the size of the adenoids and of the tonsils grows proportionately to the size of the airway. In other words, normal growth does not lead to increased lymphoid tissue enlargement, and that therefore any deviation from the normal growth trajectory should be viewed as abnormal. Doesn't mean that it's going to cause disease, but should be viewed as something that has happened and most likely relates to exposure to a variety of conditions that may lead to this increased proliferation of the tissue, and I'll touch on it a little bit later today. So two things need to be remembered. One is that when we transition to sleep, we have increased upper airway resistance. There's reductions in airway diameter, and there is reduced tone of the pharyngeal dilator muscles. When we go to REM sleep, the tone completely disappears, and so we are flaccid muscles except for the diaphragm. In children, the most common abnormality with sleep apnea is adenotonsillar hypertrophy. I showed you this before, which increases pharyngeal resistance and leads or may promote episodic airway collapse. And adenoidal growth, which occurs primarily from infancy through childhood when exposure and reduces in childhood adolescence, and tonsils grow through the same, except that if no events occur or no disease occur, and there's no exposure, then the growth is proportionate to the airway, as I showed you. So when we take children with controls and with sleep apnea, you can see that the area where the lowest or the smallest cross-sectional area is where the adenoids and tonsils overlap. This is an area of vulnerability, and the one that is most likely to result during sleep, this is studies during wakefulness, the most likely to result during sleep in collapse or occlusion of the airway in a child with sleep apnea, as opposed to a child without sleep apnea. Now, how do we quantify? This is good for all of us to compare the Brodsky classification. We take a look at the occupation of either 25% or less of the airway by grade 1 tonsils, 25 to 50 grade 2, 50 to 75 grade 3, and then grade 4 are what we call almost kissing tonsils, or at least 75% or above. And this is important because by doing this, we will communicate between each other as to what constitutes hypertrophy of the tonsillar tissues, which is obviously very important to Another element that you may not be as familiar with is the fact that we have lingual tonsil. One that for many years we have not paid attention, but turns up to be quite important. And so today, by the grading of the size of the lingual tonsil is important. Grade 1 is none to minimal. It's at the base of the tongue, close to where you see the epiglottis. Grade 2, that's more than less than 50% filling of the vallecula. 50 with effacement of the vallecula, and then you cannot see the epiglottis as grade 4, and that could be the contribution, even in children after adenotonsillectomy, the contribution to recurrent or relapsing sleep apnea in many children. So what have we learned? We have learned that MRI shows us that children with sleep apnea have larger tonsils and adenoids than controls. The presence of markedly enlarged tonsils may not always lead to OSA. You may have kids with kissing tonsils that will not have sleep apnea, and that therefore we need to start thinking of very complex interactions between anatomical components and other factors such as upper airway tone, respiratory drive, etc. And I'd like to dedicate a little bit of time going through these so that we all understand that even if you see just enlarged tonsils and adenoids, and even if there is snoring, doesn't necessarily mean that the child will have sleep apnea. There must be other factors that contribute to this actually manifesting as a true disease called obstructive sleep apnea syndrome. The first one is, how can we measure collapsibility? And this is something called the critical pressure, PCRIT, and this is a work by Carol Marcus. Carol Marcus was unfortunately she passed away, but was a colleague with whom I had the privilege of working during our early years in our careers. And what she did was a wonderful work, was to take children and then apply negative pressures while they were asleep and see when the airway would collapse during sleep. And so the more negative the pressure that you need to apply in order to collapse the airway means that the airway is less collapsible. The more positive it becomes, the more collapsible it is. So she plotted the apnea index, in other words, the number of obstructive apnea events per hour of sleep relative to the critical pressure. And you can see that as the pressures become increasingly towards atmospheric pressure, 0 is atmospheric pressure, that these kids start developing a significant sleep apnea that is therefore leads to obstructive sleep apnea and manifests as a disease. So what this told us for the first time back in 1998, a very, very seminal work, was that the collapsibility of the airway during sleep is much higher in children with sleep apnea, and that this occurs as nearly atmospheric or above atmospheric pressures. In other words, you don't even need to make an effort in order to collapse your airway. But we did the same in wakeful kids by just taking away some of the proprioceptive elements of sensation that keep our airway awake. If you know, and you know that very well, you don't snore during wakefulness. That means that during wakefulness, there are mechanisms that proprioception and then your wakefulness drive to breathe that keep the airway open, and therefore it will not collapse. So by taking away through topical anesthesia of the airway for a few minutes, you can see that, and then measuring the change in upper airway cross-sectional area with an echo Doppler, you can see that kids who are controls do not collapse their airway even though you anesthetize them, you topically anesthesia, and that kids with the triangles, open triangles are kids with sleep apnea, they really collapse a component of their airway very quickly in topical anesthesia despite being awake. That indicates that the collapsibility of the airway can be measured both during wakefulness with non-invasive and non-radiological techniques, no radiation, and that by doing so, we can predict who are the kids that have sleep apnea, and indeed we were able to reproduce that in a very large cohort of children. Again, the important point being that these kids with sleep apnea have increased upper airway collapsibility. So how do we look at this altogether? And this is kind of the summary of the pathophysiological mechanisms. We now today know that there are multiple endotypes. And what we refer by endotypes is that there are certain elements in the pathophysiology that are intrinsic to this particular patient. And so there are multiple possibilities. It could well be that just the presence of impaired upper airway anatomy may lead to sleep apnea. For example, kids with Pierre-Robin sequence. They have very small airways, the airway is compromised, therefore you don't need all the other elements to have upper airway obstruction during sleep. You may have very large tonsils and some retrognathia. All of these are anatomy, and so they may lead to mechanical loads that lead to so much collapsibility that they will manifest as sleep apnea. But that is not necessarily the case. And so you may have a dominant endotype, but it would be unlikely that it would alone manifest. And so you want to define what are the other elements that are important and how can we identify them. And today we have techniques during sleep studies to measure each one of these in a very relatively accurate way. So we can look at the upper airway responsiveness to sleep. In other words, if you have neuromuscular disease, do you have the appropriate neuromuscular response in order to maintain the airway open? You may not have any adenotonsillar hypertrophy or very little, but if the muscles or the neuromuscular response is weak, such as, for example, in Duchenne muscular dystrophy or in normal kids that have very little reflexes, this may translate into the factor that dominates the collapsibility of the airway. The same way, if you don't wake up, if you need to wake up only when you reach very significant efforts of breathing against a resistance, or you need to have carbon dioxide levels that really are very high, then this low arousal threshold may lead to a more severe manifestation of sleep apnea. And by the same token, ventilatory control instability. You have what we call high loop gain. If you, for every component of low levels of oxygen or a component of sensitivity to carbon dioxide that is low, you may have what we call a very high gain into the system. And by introducing this, you create instability that makes that events will take place and then stop and event and stop. And so the patterns become very different. So I'm going to simplify to take all of these endotypes and you divide them into two in what I call the balance between mechanical loads and neuromuscular responses. Mechanical loads will push the collapsibility, this arrow up towards snoring, mild OSA, and so on. And the neuromuscular responses, if they're increased, will or abnormal, will also push towards this event, so that the collapsibility, what we see here as the peak rate, will show increasingly more positivity towards the more severe disease. This is a good schematic to illustrate the complexity of interactions that happens during sleep for any individual, and how these elements, as they play into as a constellation of all of them together, will dictate what happens at certain stages of sleep, and the variability that can happen, for example, between REM and non-REM sleep can be very readily explained by this diagram. To make it even more simpler, let's take the three craniofacial elements, airway occupying elements, and neuromuscular reflexes. And by doing this, you already get what are the contributions, at least conceptually, of a Venn diagram and how they play with each other to facilitate the occurrence of pediatric sleep apnea. Now, there are genetic factors, and we would be remiss if the two parents have sleep apnea, the probability of the child of having sleep apnea is multiplied by tenfold. We see that African Americans and Asians, as I mentioned before, are at a higher risk due to some craniofacial features that are genetically determined. Sleep apnea is clustered in families. As I said, parents with sleep apnea will have more likely to have kids with sleep apnea. But what we know today is this is clearly a polygenic disease with genes that impact the oral mucosa thickness, facial structure, and inflammatory pathways, all of which then can facilitate, through this polygenic component, a higher probability of sleep apnea or its morbidities. And therefore, today, with gene variability studies and polymorphisms, we have come to the conclusion that there are probably about 220 genes that play a role in the concept of risk of sleep apnea or risk of sleep apnea consequences, that therefore you may have sleep apnea, but now you may develop the morbidity that will trigger a treatment and be more sensitive to its consequences. So again, I wanted just to remind you again, adenotonsillar hypertrophy, obesity, and then look at all these elements that could be playing a role: hypotonia, muscle weakness, prematurity, nasoseptal obstruction, enlarged soft palate and uvula, microglossia, hypotonic pharynx, lingual tonsils, lymphatic malformations, metabolic storage disease, micrognathia, maxillary hypoplasia, and of course hemangiomas and vascular neoplasms of the airway. So these are again another way of reminding you, in addition to the conditions that I alluded earlier, to the probability, or at least start thinking of sleep apnea if you encounter any of these conditions. Now, obesity obviously is very important, particularly now that we have a pandemic of obesity around the world, certainly in children. And many studies have been done, some by our group, others by other groups. The prevalence of sleep apnea disease increases to 20 to 40% in the obese population. I'll show you a community-based study that we conducted in Spain in a second. The presence of obesity clearly adds to the risk of sleep apnea. And in fact, the group of Susan Redline at Harvard showed that for every increase in BMI by 1 kilogram per meter square, the risk of OSA increases by 12% in older children and adolescents. We know that there are fatty deposits. I will show you a little bit of that. But how could we, conceptually, how do we understand the contribution of obesity into the risk of sleep apnea? Well, we know that we have deposits of fatty deposits in the apharyngeal area. They encroach on the airway and they create a narrow and circular airway rather than the elongated ellipse, which then contributes to relatively vectors of force that are not as good in maintaining the airway open. You can also have adipose tissue, of course, in the abdominal wall and thorax, which leads to increased respiratory load. So that is reduced lung volume and reduced diaphragmatic excursion, particularly when supine, because abdominal fat and the abdomen pushing the diaphragm upwards will reduce the overall size of the lung, particularly when you're on the supine position. And if you do, your oxygen reserve will also be reduced. You have increased work of breathing. All of this make it that you're more likely to start developing the consequences of any upper airway resistance or obstruction during sleep. Therefore, you will have more likely a more severe disease if you're obese. So the NANO study was conducted in Spain. It was a multi-center study that we conducted prospectively. We enrolled almost 250 children that were obese, defined healthy, obese as defined by never suspected for sleep apnea, never had solicited any intervention. They were considered completely healthy obese. The only thing that they had was that they were obese and more than 95th percentile, adjusted for age and sex. They were between the ages of 3 to 14. And what we did a variety of things, but the important part is that we found that, first of all, there was a high number of respiratory events. And depending on the criteria that we use, between 20 to 40% or 45% of the kids, depending on whichever criteria we decided to use, would have evidence of sleep apnea, mild to moderate to severe, even though it was absolutely unbeknownst to these kids that they were actually having sleep apnea. So you can see that even in the general community population, we find a very high prevalence of children. So children with obesity, please ask if they snore. And by all means, consider that if they have any of the symptoms that I attributed to, then they need to be evaluated. So in obese children, at any level of sleep apnea severity, the size of adenoids and tonsils that is required to achieve that level of respiratory disturbance is smaller than that of lean children. So obviously, the impact of obesity is a major component and can elevate the propensity from 2.5 or 3% of the general non-obese population to 30 to 40% in the obese population. And this is a study again by Dr. Ahrens, more recent, where it shows the deposition of abdominal fat into the airway, shown here in yellow on the picture. Again, you can see that the abdominal fat deposition is also quite impressive, and that drives certainly the diaphragm up, but also is a source of inflammation, and we'll talk about it more when we talk in the next presentation. And when you look into proportion, all of the segmentation of each one of the structures, adipose tissue becomes a major component to facilitate the collapse of the airway and the restriction of the airway when you have obesity in these children. I wanted to also illustrate that if you measure that by using gene transcription or transcriptional regulation, this is a study now from a long time ago, where we showed that in children with sleep apnea, if you look at the gene network pathway, what you find is that the inflammatory response is the one that is overrepresented. And therefore, if I wish, I would say that sleep apnea is a chronic, low-grade, systemic inflammatory disease. So again, I will repeat, you need to look at sleep apnea disease as, even in non-obese children, as a low-grade, systemic inflammatory disease. And that is a very important concept because it relates to many of the mechanisms that lead to the consequences of sleep apnea. As evidence of that, you can measure it even in the airway. And we developed this contraption with Dr. Goldbart during his fellowship with us, where we measured exhaled condensates from the breath that is going through the airway. And we found that they were loaded with cytokines. And again, when we looked into the tonsils, we found that there was increased receptors that were present on the left, children with sleep apnea compared to those without sleep apnea with recurrent tonsillitis. They have increased inflammatory receptors that attest to, more importantly, the presence of cytotoxic lymphocytes and T-cell memory lymphocytes that then allow for the production and induce the production of TNF-alpha, interleukin alpha, and interleukin-6, among others, indicating that this is a real inflammation of the upper airway that is taking place and increasing the propensity of the proliferation of these tissues within children that are affected. And increase, again, as we measure those, we can measure them in the exhaled condensate as well, such as leukotrienes, and we can reduce their proliferation by topical corticosteroids, both in vitro and in vivo. So I will just give you a final as to the distinction between obese and non-obese. We decided to coin them type 1 and type 2 relative to diabetes because of the same analogies. Type 1 sleep apnea is the non-obese child that has hyperactive behaviors. Is then likely to show that kind of daytime sleepiness. Sleepiness is manifest here mostly as hyperactive behaviors, and they may come with recurrent ear infections, but are unlikely to show insulin resistance, but may more manifest as left ventricular hypertrophy, systemic hypertension, and hyperactive behaviors. Type 2, the obese child, comes more likely like adults with excessive daytime sleepiness, obviously as evidence of enlarged neck circumference, may not need as much enlarged tonsils and adenoids, but is more likely to manifest with depression, certainly with systemic hypertension and cardiovascular manifestations, and with evidence of both lipids, high cholesterol, low HDL, high LDL, as well as insulin resistance. And of course, the risk of developing metabolic associated steatohepatitis, MASH, is particularly prevalent in morbidly obese children with sleep apnea, more than obese children of the same level of BMI, but without sleep apnea. So you can see that there is already some inherent risks that we need to start thinking of, and I'll be discussing these in part 2 of my presentation. So I'd like to appreciate your attention for this, and I hope you enjoyed it, and I look forward to being able to entertain and expose to you both of the consequences, diagnostic approaches, and treatment of sleep apnea in the next presentation. Thank you again. Have a wonderful time.
Thank you, Dean Dr. David Gozal, for a very informative and educational lecture. At this point, I would like to indulge you in a couple of questions on behalf of our audience. You mentioned, Dean, that obesity, about 50% of it accounts for all children with obstructive sleep apnea, up to 50%. So as a primary care physician, I would like to ask you, how does a primary care physician approach obese child? Should they always get a pulmonary sleep apnea, pediatric sleep apnea specialist consult? Would love to hear your thoughts on how would you advise our primary care colleagues who are watching this CME activity.
Yes, this is a great question. First of all, I will tackle this much more in detail in my next presentation. But if you have an obese child that is seen in your clinic and reports that by parents that he snores, so I will allude to questionnaires that will be distributed and so forth next presentation. If there is a snoring, if there is fatigue in the morning when waking up, there are other symptoms of that would be conducive to think that this child is not doing very well. By all means, I think that one of the first thoughts that needs to occur is maybe this child who has obesity needs to be evaluated for sleep apnea. Let's say that you find in addition that he's insulin resistant, or he has systemic hypertension, or he is very tired and falls asleep in school, or he is very tired in the morning and has a headache, or he has very restless sleep. So you can see that there's a constellation of indicators that by subtle questioning can already guide you towards the assumption that this requires a little bit more evaluation in the context of sleep.
Thank you. One more question. You mentioned, and I was intrigued by so much research that you have provided for us to see that there is a robust science behind what we know about the snoring child. But I was particularly struck by this statistic that 1 kilogram increase in BMI increases the risk by 12%. So the question that I have for my colleagues is reverse the true? How does the weight loss affect the sleep apnea? In other words, if you reduce the weight, would it improve the sleep apnea, and to what extent?
Well, this is obviously a very actual and recent study, a Surmount study published in the New England in 2025 by Malhotra and colleagues in adults. They used GLP-1 agonists, which is obviously we are now in that era. So obese patients with sleep apnea, adults, were treated with tirzepatide, one of the GLP-1 agonists, and showed that they could reduce the severity significantly, at least between 30 to 50% of the severity of sleep apnea could be reduced by about 20% or so reduction in BMI. So reductions in body mass index will translate into obviously reduced deposits in the upper airway, the reduced deposits within the abdominal cavity, reduced deposits of fat into the chest, and by doing this, improving substantially on the mechanics of the upper airway and mechanics of respiration, thereby leading to an improvement in the overall collapsibility of the airway. Remember that obesity is also a chronic low-grade inflammatory disease, so reduction in the overall adipose mass, particularly the visceral adiposity, will reduce the level of inflammation, which then translates again to less symptoms and a much better well-being for the patient, as well as reduced collapsibility of the airway, because inflammation in the airway will trigger also collapsibility. So all of these mechanisms that I alluded to get markedly improved when you start reducing weight, and the more you achieve that towards the normal BMI range, the more likely that you will be able to eliminate a very substantial component or proportion of the severity of the sleep apnea that is apparent in these patients.
Thank you, Dean, Dr. David Gozal, again for your time. And at this point, I would like to also thank our participants in the CME On-Demand Endurance activity titled Snoring Child. Snoring is more than just a nuisance. To get the credit for this program, in accordance with the ACCME accreditation standards, you must complete the evaluation at the end of this program. Your feedback is essential for assessing the effectiveness of this activity and for improving future educational program. To complete your evaluation and claim your CME credit, you may scan the QR code with your phone or click on the link below in the next slide to access the evaluation form. Physicians should only claim credit commensurate with the extent of their participation in this activity. This content has been developed in compliance with the ACCME's standards for integrity and independence in accredited continuing education, ensuring it is free from commercial bias. On behalf of the Marshall University School of Medicine, on behalf of our Dean, Dr. David Gozal, and myself and my CME team, we appreciate your commitment to lifelong learning and your dedication to improving patient care. Thank you all for your participation, and thank you.